Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. Good evening and welcome to Pause for the Truth. I am your co host, Jocelyn Turner. It is a gorgeous, absolutely amazing day here in Northeast Florida. I don't know where you are, but it's just, Dr. Kane, the weather is just unbelievably beautiful here. How are you doing today?
I'm doing fine, but we're gonna lose some of our listeners because we keep bragging about how great our weather is here, and those guys make me jealous where they're located. So, but that's just too bad.
I know, right? We're just gonna listen. We can say it's a beautiful day today, but in the next 2 days, we may say, "Oh my God, this heat is killing me," because it's supposed to be in the 90s, Dr. Kane.
And that's quick too. Look, I make sure I have my air conditioning service today, just in
Well,
case.
and I'm glad you mentioned that because this is an opportunity for us to say real quickly, if you have senior citizens in your life or others who may be homebound, make sure you check on them and that they understand that it's time to switch the thermostat from heat to cold to hot to, you know what I mean, from heat to cold so that they won't have any extreme temperature illnesses within their house. Well, Dr. Kane, I'm excited that we have someone very special to me joining us tonight, Dr. Kane, a blast from the past. So tonight,
Over a million years ago.
so this evening, joining us are two dynamic folk who are just rocking and rolling, doing some amazing things around the country, and they are with Prevention Institute. And introducing my good friend, oh my goodness, just the blast from the past. We did some amazing things when we worked together at the health department here. Dana Fields Johnson, how are you doing this evening, Dana?
It is a blast from the past, Jocelyn, and I'm, really excited, also honored that you and Dr. Kane thought that uh, me and my colleagues were worthy enough to come on and be a part of your podcast because I've listened to some of the folks before. I listened last week, and you've had some great and honest. The reason why I'm excited to be here is because, one, I remember that Dr. Kane was a physician of the people, right? And just so respected and really came with that community lens. And Jocelyn, I always tell people that the work we did as a part of the Duval County Health Department, I think was cutting edge for a health department in Florida at that time. And so I'm very proud of some of the stuff we seeded there. I will tell you that a lot of what I learned there from you, from Charles Griggs, from others, and learned collaboratively working with you and with the community, because that was something we were prioritizing then, has given me so much that I draw on and take into my work at Prevention Institute. So thank you. And I'm really excited to be in conversation with you. And I will say that I told Dr. King when he came on, somebody aged. I'm not sure if it's one or both of us, but it has been a minute, and I'm so glad to be here with both of y'all.
Thank you, Dana.
I look like it. She don't.
I do.
Thank you, Dana. And thank you for asking your colleague Ruben Cantu to join you on the podcast tonight. How are you doing this evening, Ruben?
I am doing great. For me, it's still afternoon. I'm calling in from Oakland, California.
Oh, wow.
Very happy to be with you all today. Dana has spoken very highly of you, Jocelyn, and you, Dr. Kane, and I'm just honored and humbled to be part of this conversation with you all.
As she's done the same for you, Ruben. So don't think she's just just talking about us. She's also talked a lot about you. So, you know,
Good people find each other, Jocelyn.
Or
I
you,
know,
or
right?
you a very good politician. Well,
Good people find each other, committed people find each other, and people who are carrying the charge, I think, for health equity and racial justice tend to congregate in the same spaces.
You know that's so true. And you know, with it being Minority Health Month, we like to focus on issues that we know that are prevalent and relevant to our communities. And so to learn from you all and hear the great work that you're doing, Dr. Kane and I, before we start a podcast or even vet which topics or people to invite, we do our homework. And you know, when I share with Dr. Kane where you are with Prevention Institute, then he, you know, immediately started looking. So he was like, oh yeah, we need them on, right? And so if you would first start, you know, tell our audience a little bit about, and one or both of you, tell us about Prevention Institute, and then we'll talk specifically about some of the work that you're doing.
So I'll start, and Ruben, jump in if I miss anything that we think is particularly important to know. We're a national nonprofit. Ruben is actually based in our headquarters in Oakland, but we also have offices in LA and Houston, and I'm a little bit of an outlier. I am here in sunny Florida as well to make the people jealous. And we have a presence in Washington, D.C., where our policy director is also, where she lives and works and carries forward a lot of our work at the federal level. Prevention Institute has been around, I think, about 25, 26 years now, 1997. And we really exist to work with communities and partners around the country to embed equity and key policies and actions for equity and prevention in federal, state, local, and organizational policies. And key word for us is really prevention, and we give particular lens and focus to primary prevention. Our vision is that we have a vision for thriving and equitable communities where all people have what they need in their communities to live, learn, work, play, and even I like to add the word pray as well, right? We've heard that before. But we know primary prevention is such an important lens, and one that doesn't always get the attention it needs. For us, primary prevention is addressing illness, injury, premature death in the first place before it exists, right? We know that on certain issues we work on around violence, around substance use and misuse, that there is an urgent need to be in that tertiary space or in that space where we're providing services and looking at treatment and recovery, right? And giving people what they need to recover from those things. But we also hear all the time, I heard it on a webinar we were hosting yesterday, that if we don't get to really addressing, one, root causes, and two, investing in primary prevention, we're going to keep spinning, right? We're going to keep addressing and readdressing the same things. So we really work with diverse, even though those are the locations our staff are in, we work with diverse communities around the country. We've worked with so many different places. We work with diverse communities, but also diverse partners and agencies at the federal, state, and local levels. We also work with foundation partners and community-based organizations to really embed primary prevention into their practice. We do a lot of training and facilitation around the country to think about what a public health approach to things like violence and substance misuse and use is. So hearing that, really means that one of our key audiences is public health, but we also do a fair amount with folks who represent health systems, again, philanthropy partners. And my favorite work is the work we do to engage community and community-based organizations and solutions, and really advocating for the changes that they want to see in their community environments.
Ruben, did you want to ask? Thank you, Dana. Ruben, is there anything you'd like to add?
You know, Dana does such a great job about talking about the work that we do. The one thing that I, you know, Dana said that, you know, the key thing here is thinking about prevention. And I think if I was to think of another key word to go with the work that we do, it would be community. And we try to keep community at the center of everything that we do. You know, we're very firm believers that community members, residents, they're the ones who are closest to the challenges. So they're the ones who know what's happening. And they're also the ones who know what the solutions need to look like. And, you know, sometimes, you know, a community member or a resident might not know the intricacies of, like, how do I advocate for this kind of change we need to see happen in the community, right? Or, you know, they might not know that you need to take it to your city council or the mayor or this person or that elected official or whatever. And we're the kind of organization that we can come in and either help them figure out how they can do that, work with the organizations that they work with to help them do that. Because, like I said, we know that community members are closest to the problems, but they're also closest to the solutions. And we need to make sure we're listening to that voice as we're doing the work to improve health, improve safety in our communities.
That's so important, Ruben, because oftentimes people go in and want to tell communities how to do things. And they're like, right, you don't live here. You come from wherever you're coming from, right? You have no idea about our community. And so, you know, to hear that you are very community oriented and community focused and engage with the community to hear their voices, that's very cool. How do you all decide what communities to go into in doing the work that you do? Do they seek your help, or are they recommended by someone, or, you know, just tell us about that.
Great question, Jocelyn. It really starts with people usually seeking us out. They've either heard one of our staff. So you said Ruben and I do all this great work, and I really want to honor my colleagues who probably are listening. I heard some of our junior and younger colleagues were definitely going to tune in. So we can't take credit, Ruben and I, for anything, because one thing I really love about Prevention Institute is that we're collaborative internally and most of all externally. And so I work with some of the most talented and brilliant folks that, you know, outside of you, Jocelyn, I need to say that. Nobody compares to JT Turner. But a lot of times it starts with somebody experiencing our work at a conference. I remember in work we were invited to do and contracted to do in Ohio in 2016, 2017. Both Ruben and I were pretty new at PI, but were assigned to the project. They had just been looking at some of our frameworks online and said, we think this is missing from our conversations about how to approach substance misuse and the opioid epidemic in some of their counties. We've heard similar things about violence, and we don't talk about it as violence. We talk about it in the affirmative, right? What we want to create for communities, which is safety, community safety. And so City of Milwaukee, I remember when they invited us to come and work with them on their comprehensive citywide plan. They had been looking at our materials. They had heard our executive director at a conference and said, we need to work together. So it often starts with people just experiencing us, hearing that we're approaching things differently. Like Ruben said, really centering and valuing community voice and community power, right? That we're not doing anything for community, but really working alongside community and supporting them in whatever they say the work is and the changes that they want to seek in their community environments. I think Going back to something you said, Jocelyn, that really resonated for me. We hear that all the time too. We heard it when we walked into Milwaukee and into Ohio. Who are these folks y'all brought from California to help us do our work? We know our community better than they do. And we appreciate hearing that, right? And we say to folks, we walk in with we try to exercise a lot of humility when we walk in, and tailor something that is for that community, right? We have standard tools and frameworks and things that we've developed to support the work, right, that we bring in, but we really tailor it. We ask people, what is it you want to accomplish, right? And then we think about what we have that might be modified or adapted or used for them to approach whatever the issue is, be it community safety or healthy eating, active living, or violence, or more and more people are asking us to apply our framework to mental health and well-being, because we know that's such a huge concern, particularly really before the onset of the pandemic, but afterwards. Lots of people flocked to us. Things kind of shut down in a lot of other places, but I always tell people Prevention Institute's approaches were amplified, and people really saw, okay, there's something to us thinking about primary prevention more, because the communities most impacted by the pandemic were people in communities most impacted by chronic disease, by violence, by all these other things. And that's by design, right? And that is because these things are embedded in systems. They're embedded in, and driven by things like concentrated poverty and policies and practices that historically have, shaped our communities. And Ruben, I saw you unmute, so I'm gonna stop talking here.
Yeah, everything you're saying is right on. One of the things you said, talking about the work we did in Ohio, that makes me remember it was, sometimes it's really hard for people to get the need for prevention, especially when we're talking about things that are such huge immediate concerns in communities that we work with, like violence, like substance use, like the opioid epidemic. And we come into these communities saying, we need to think about prevention. And their response is, we're just trying to stop the bleeding right now. We're just trying to, get people who are on the streets overdosing, getting naloxone or like other things in their hands, or we're just trying to address these immediate problems. And it takes a lot of concentrated effort for people to think about what it is that we need to do to be able to prevent that stuff from happening in the first place. Should I tell the story, Dana? I'm going to tell the story. The river
Stories are always good, and it's honest.
So there's this
podcast host you're with today are two of the most honest people we could be talking to. So yeah, we should tell the story.
Like so we tell a story a lot of times around the importance of prevention, and it's the story about three sisters who were walking along the banks of a river, and they come across a number of small children who are in the river that kind of seem like they're floundering in the water, drowning, trying to keep afloat. And so one of the sisters jumps in the water and starts rescuing the kids and starts pulling some of them out to the shore. The second sister jumps in and starts teaching the other kids how to swim so that they can stay afloat until somebody can get to them to rescue them. And the third sister starts walking upstream to the other end of the river. And when the sisters notice that she's doing this and that she's walking away, they kind of call to her and say, hey, where are you going? We need your help here where there's this emergency happening. And her response is, that's really important, and we need to do that. You all seem to have it in hand right now, but somebody needs to go upstream and figure out why these kids are in the river to begin with. Figure out what's the root cause, what's happening to let these kids fall into the river. Was there a bridge that kind of went out? Was there something that happened that's like letting these kids fall into the river? And until we do that, we're just going to be standing in the river, pulling kids out as they're drowning over and over and over again, and we're never going to solve the problem. And a lot of times telling that story for folks kind of gives them the aha that, okay, now we kind of get why it's important. Because if we don't do that, if we don't figure out what's driving whatever the challenge is, people are we're just going to get stuck in the same old thing, doing the same thing and trying to rescue people and trying to put Band-Aids on these wounds. And some of the wounds that community members are facing are really deep, and they're really old wounds.
Yeah.
We need to do what we can to try to figure out where did that come from, and asking people that question. Like we asked the people in Ohio that we were working with who had a lot of doubts about us at first. What do you think is driving the epidemic here? What do you think is driving the opioid epidemic? And at first we were getting responses which were, people are overprescribing medications, which is true. And there's like a culture of like sharing medications with family members and friends, which is true. But then we went a little bit deeper than that and said, okay, but what is it that's driving people to turn to those substances in the first place?
Mm-hmm.
Right. And that's when we started hearing from folks about, factories closing down and the lack of affordable housing. And we would hear stories like this factory closed down, so the people that lived in that neighborhood, had to move to another town or another part of the state. And so that was kind of like decimating like the social network and the social fabric of the community. And people who had been neighbors for years no longer had their neighbors, and the people that they relied on and the people that they knew for generations anymore. We started hearing things about like the concentrated poverty, the fact that there was a lack of investment in those communities, people shutting down grocery stores, shutting down other businesses. And so we were able to then work with them to figure out like, okay, if those are the things that are driving the epidemic, why don't we think of some strategies there also, in addition to the things that we know we need to do, like getting overdose prevention stuff in people's hands. And I think that really turned it around for folks, where by the end of the project that we did, we were able to get people to say that like the work that we were doing with them and getting them to think about it in this way was one of the best things that they ever did, because they could actually then see the reason why they needed to focus on prevention.
Ruben and Dana, the approach that you guys use in terms of individualizing the community is great, because that does help for that particular community, because there's no universal answer that applies to every neighborhood. But here in Jackson, here in Northeast Florida, one of the biggest things that we see is the disparities that take place in terms of care, especially as it relates to prevention. We don't see within the Black community, in all fairness, we don't see within the Black community as much opioid abuse that we see in other communities. So in our communities, what we wind up seeing is, the systemic racism, unequal access to healthcare services, unequal access to just even housing and things of that nature that may drive people to utilize drugs of some, one or the other. But since you mentioned prevention, the thing that we have to do, or what we focus on, is trying to allowing people to have access to healthcare services. And a lot of that begins with them having, if we're looking at a federal level, we're looking at the most recent thing from Republican-led Congress, in which they're trying to right now take like $4 trillion away from the Affordable Care Act. I mean, that goes toward the Affordable Care Act, which help all communities. And but if we only we only address specific programs in which you should, in that specific community, there's a generalization in which all these same communities need access to funds to be able to help places to receive help from places like the Prevention Institute. Health and health equity and racial justice, that was funded okay in 2022, 2023 in California with Governor Newsom. I know that was part of their budget, that they particularly go after funding that type of situation. I double dog dare you to find that here in Florida, because it's not.
Florida is a tough place, Dr. Kane, and I listen. I feel blessed to have spent 5 years in Northeast Florida and 2 more years in Gainesville back in the day, but I can't say that I wasn't happy to go and experience the movement around prevention that was happening in California, right? It makes it easier because there's political will for it. There are partners who are down for it. There's resources and investments, right? In equity. And actually, I'll just drop this tidbit. One of our former colleagues, Dr. Larissa Estes, just became California's first, I think, director at the state level, their director of racial equity, right? Am I saying that right, Ruben? And Larissa was at PI when I first got there, leading some of our work around mental health and well-being, and also work on health systems transformation. To get to a couple things you said, Dr. King, one of the other really great things about our approach around driving people to a primary prevention lens and driving people to look at what's going on in the community environments around them, because this happened in the Ohio work too. And I thought, Ruben, you were going to tell a different story when you told the story of the 3 sisters, but I'll tell you, when we walked in, most of the room was primarily Caucasian and from very rural areas. I like to joke, and I hope this is okay to say on the webinar, and I hope it's not offensive to anybody, that they sent the 3, including our managing director, Sheila Savannah, they sent the 3 brownest people at PI at the time to go and work on this project in Ohio. And literally we were going, I think early on, we were going a lot, right? There was a lot of travel for that work. But one of the other things, and this really does tie to something you said about not being an issue or a disparity or an inequity that you see in the Black community here in Northeast Florida. But one of the points, because somebody said to us directly, I love it when people are transparent, because that tells me what I need to, that gives me an opportunity to go back and strategize. Okay, what are we really dealing with here? And how do we take this and really tailor it to what we're hearing, right? But one of the first things they did at the end of our presentation in the first session was say, that there may work in those urban communities you work in, but I'm not sure it's going to work here. Guess what? By the end of that work, like Ruben said, they were dying to hear from us every time we walked in the room, because we were able to show them that the same thing, the same drivers and root causes that they identified around what drove the opioid when they saw the opioid epidemic really take off in their community, aside from those things that were about overprescribing, that were about those other things Ruben mentioned, things like, you know, under and disinvestment in their communities, loss of industry, loss of jobs was the biggest thing they talked about. Guess what? Those are the same drivers of what we talk about as the crack epidemic in the 80s, right? People didn't have opportunity, right? And we were able to show them that by asking that simple question. And we actually had them do 3-minute videos where they were talking about, right, these issues. So just want to make the connection that that is one of the values of bringing a primary prevention lens to it, that really ask people what about your community doesn't support health, safety, and equity, right? Or support opportunity, or support you thriving and being able to accomplish dreams and goals that you have for yourself, your family, your children. And that is a great starting point for people to identify places that they can be involved in advocating and changing and transforming the community environment. Access to healthcare, we know, is an issue, Dr. Kane, and particularly access to culturally competent healthcare, which we know makes a difference. We hear that in when we're working in immigrant communities, we hear it, you know, in Latino communities, we hear it. We're doing a lot of work with partners who are focused on Asian American mental health in Houston. And so I just heard one of them say, like, we come over from our country. They were kind of Middle Eastern, right? Asian. We come over from our country, we're doctors, and they don't let us work in our community or honor the training we've had here. That would do a lot to really overcome some of the inequities and disparities there, right? So we know access to culturally competent healthcare is an issue, and we don't not work on those things. We, again, have worked with health systems, worked with physicians as advocates, and you know, work to actually connect community or support connecting community to healthcare providers. And we also say that we know that health is not just a clinical or healthcare issue, right? We know so much that how our communities have been shaped up, and then structural racism and the things that have been embedded in systems intentionally or unintentionally has disadvantaged communities of color.
You
Yeah,
know, a perfect example of that I was going to say was the method by which they were using to determine kidney transplants. I mean, you know, the markers that they were using were.
I read this recently.
Okay. So
keep talking about it, Dr. Kane. I didn't mean to cut you off. I just recently read something about this coming out. Yeah.
Well, we, as Black physicians, you know, the Northeast Florida Medical Society is local representation for the National Medical Association, which is the national, you know, Black physicians, basically, organizations equivalent to the AMA. And for years, we've been discussing as to, you know, the mechanism by which they were using to determine the functional status of kidneys and how well people's kidneys are. And, you know, they call it estimated glomerular filtration rate. And the way that it was a racially biased formula in which it made the kidneys of African Americans or Black folks look to be functioning much better than those, at least by 10 to 15%, much better than those of our Caucasian counterparts. What we wound up seeing on that is that you had a much greater or much earlier referral to kidney transplantation in non-Black individuals than white individuals. I mean, by thousands, you know, to 18 to 30,000 were sitting on waiting lists in which they actually would have qualified had they used a race neutral formula. They finally started using more of a race neutral formula. And then after that, I mean, you had within a matter of 3 months, probably another 2,000-3,000 individuals that became eligible for a kidney transplantation that should have been much earlier. but it was just like that, almost like the snap of just by changing the formula, it allowed much earlier renal transplantation or kidney transplantation in people to, even though that's not a primary prevention, the disease had already took its toll. And we can go back to primary prevention because that's the stuff that I try to do every day to keep them off the transplant list. But once they were on the transplant list, you know, there was no fair treatment, not necessarily intentional. You know, it might have been unintentional. Intentional or unintentional, if you shoot me, I'm still shot.
Right. That was
Okay.
my point. Whether things are intentional or unintentional, the outcome is still the same, right? And it's not the outcome we want.
Yep. If you're just tuning in, I just want to hold on 1 second. If you're just tuning in, we're talking to the folks from Prevention Institute, and we're talking about something that's near and dear to our hearts: improving health, safety, and well-being. Right. Well, these folks do it through a focus on health, equity, and racial justice here in Northeast Florida and Florida in general. Talking about equity, unfortunately, health equity and diversity and inclusion, all those other words that seem to be offensive to folks. But folks have to realize our reality and our truths, that there are communities, unfortunately, who lack resources that, unfortunately predispose them to so many different conditions that, you know, had they had the opportunities. We had some folks talking recently about redlining on the show. So, you know, there are so many people who are unhoused nowadays. So we haven't even gotten into that. Yesterday, when we turn on the news, it's always something different, but it's repeating over and over again. You know, where the school bus was shot at, the bus driver, the bullet went right to where the bus driver was seated with children on the bus, right? So when we talk about those things, Ruben, I don't know if it were you who talked about, I like how you said using safety instead of violence, right? Because if people think, we all should want the same thing for every community, and that is for our families to live in environments that's safe for us to thrive, and all of our family members are healthy and safe. So I want to give you both of you an opportunity. You kind of gave us some little snippets, but tell us about some work you've done, and when you left there, you felt like, man, that was great, right? Like, oh, I hope we get a chance to do this again somewhere else. Is there anything that comes to mind for either of you? Something you've done so much, so I know it might be hard to narrow it down, but what is something you're particularly proud of?
I think if you ask any one of our colleagues, right, they would probably all bring up something different. And that's one of the things I love at PI is the breadth and scope of our work and getting to work with different communities around the country. We talk about ourselves as a learning organization because we learn something from any place that invites us to come and work with them and share what we know, and we take it and we then add it to what we know. We lift up those communities as examples. I'm actually going to let Ruben start that. I bet I know what he's going to say, though.
I'm curious if I'm going to get it right. But you know, one of the projects that I was involved in at Prevention Institute when I first started here was a project called Making Connections for Mental Health and Well-Being Among Men and Boys, and it was an initiative where we had a funder who came in and provided funding for us to build a learning community of 13 to 16 organizations across the country that were working to improve mental health and well-being for men and boys. And two kind of populations there. One was military service members and veterans and their families, and the other group was young men and boys of color. And so we worked with groups from all across the country that were working with those populations. Probably about 2/3 of them were working with men and boys of color, and the other third were working on military service members and veterans. And the reason why those two groups is because they were the groups, the funder for this project was specifically focused on men and boys and mental health. And when we did our research, those were the two kind of subpopulations among men and boys that had the highest rates of trauma, the highest rates of mental health challenges. And you can understand why, because they're, folks that military service members and veterans, they're folks who, face violence and face trauma and face a hard time coming back from their service sometimes. And they're not treated with the respect, and they don't find the services that they deserve. And then with young men and boys of color, just compounding different challenges, from racism to inequality in income and education, and just that segregation from opportunity that Dana was talking about earlier. And we basically worked with these groups for 6 years to help them figure out how they want to develop strategies in their community to address and improve mental health for their young men and boys. And the one that always sticks with me is a group that we worked with in San Diego, California, called United Women of East Africa. And they were a group that was formed by immigrant women from East Africa, a lot of them from Ethiopia, from Somalia, and a few other places. And they were immigrant women with young men, with young sons who they knew were facing mental health challenges. And when you would talk to those young men who were like high school age, middle school age, they would talk about the challenges that they were facing and how it felt like they were having to wear multiple masks every day. They had to act a certain way at home with their parents. They had to act a certain way in school with their peers. They had to act a certain way out on the streets, hanging out with their friends. And it was something that was just exhausting for them, wearing them down, and leading them very vulnerable to things like gang violence, to drugs and alcohol and other substances. And it also very sadly was leading to suicide in a number of those young men too. And what they wanted to do was they went around and asked folks in the community, like, what is it that's causing these challenges for these young men? And what is it that's causing the stress, the anxiety, the challenges that are driving them to these like health deteriorating activities? And it was a lot of the same things that we've been talking around not being able to access mental health services that were culturally and linguistically competent. But it was also about stresses they were facing around not fitting into schools, not being able to find jobs that paid them well, and just a lack of the opportunity for them to connect to one another, to their peers, in a safe place where they could connect with each other, connect with their community, kind of connect back to their roots, and just build community with each other. And so the group prioritized building out what they called their hub, which is basically like a meeting spot for them that was within the walls of one of the organizations in the community, where they could have a space where they could hang out after school, the young men, they could talk to each other, they could feel comfortable with each other and have each other as like a support system. And once the organizations that were working on this project saw that these young men had like built that strong, cohesive community amongst themselves, then they started introducing all of these other things into the works, and doing leadership training with them, and doing public speaking training with them, and training them on how to use their stories to try to advocate for change. And pretty soon, within 2 or 3 years, a lot of these young men who were still in high school, they were going out and attending city council meetings to advocate for more mental health services for their community, and they could talk about it from where they were coming from and what they were seeing happening to their peers. They were able to advocate for the city council and the county board of supervisors to do anti-displacement policies. So as the areas around the immigrant neighborhoods were gentrifying, they found that they were being pushed out to other neighborhoods and losing the connection to, the grocery stores and the churches and the mosques and all of the places that were home to them. And so they worked with folks to try to put in those anti-displacement policies so they wouldn't be pushed out. And it was just amazing to see the growth of that community from being able to recognize.
That's powerful.
What the challenges were and how they could try to be part of the solution.
That's powerful. Thank you. Wow. I love when you see, to me, it is a transformation of a community, and it makes you feel good that you came in and just really helped, as Dana says, frame that for them, right? They may not have, they knew what the issues were, but when you help to frame it for them and then come up with solutions for them to, take it to the next level and really make some things happen in their community. Dana, I'm going to give you a chance to answer that question. We're nearing the end of the show, but one of the things that we like to do before we end the show is and we usually do it at the midway mark, and we didn't get a chance to do that, is we have a history maker moment. So Tyrone, if you could cue that. Don't go anywhere, Ruben and Dana. We'll be right back.
Have you ever considered how profoundly different the history of race relations in the United States would have been had the 40 acres and a mule promise been fulfilled? This promise was not just a pledge, but a glimpse of a future that could have transformed the trajectory of a nation. As the first systematic attempt to provide a form of reparations to newly freed slaves, the 40 acres and a mule promise was a radical proposition for its time. It was a prospect of a transformation of Southern society more radical even than the end of slavery. This revolutionary idea was born from the discussions held in January 1865 between Union General William T. Sherman, Secretary of War Edwin M. Stanton, and 20 leaders of the black community in Savannah, Georgia. This meeting was unprecedented in American history. Sherman's Special Field Order No. 15, issued a few days after this historic meeting, is often credited as the source of the 40 acres and a mule policy. This half-truth overlooks the significant contribution of the black leaders in the formulation of this policy. Sherman's order proposed the massive confiscation of private property, approximately 400,000 acres, formerly owned by Confederate landowners, and its methodical redistribution to former black slaves. The order specified the creation of new communities to be governed entirely by black people themselves, a radical proposition that could have set a precedent for black self-sufficiency and autonomy. However, the mule, an essential tool for agrarian life at the time, was not included in Sherman's order. The mule was added later, further emphasizing the intention to provide the former slaves with the means to build, accrue, and pass on wealth. Regrettably, the promise of 40 acres and a mule was not to be realized for the overwhelming majority of the nation's former slaves, who numbered about 3.9 million. This unrealized promise signified a missed opportunity of average people being able to own land, fulfilling one of the principal promises of America. In conclusion, the 40 acres and a mule promise represents a significant moment in the history of race relations in the United States. It was a radical, progressive idea born from the discussions between black leaders and Union officials. It offered a glimpse of a future where former slaves could own land, build wealth, and govern their communities. However, this promise was not fulfilled, leaving a profound impact on the history of race relations in the United States.
Wow, when Tyrone does his history, he sure draws, I'm just like, oh, wow. And I guess when thank you, Tyrone, for that. When I watch that, Dana and Ruben, I think about no matter how much work we do, we are faced with systems that get in our way and that are getting in the way of the people who are trying to access services. How do you, in the work that you're doing, and I know, Dana, I had a pending question for you, so I want to get back to that. But I also want you all to start thinking about how do you deal with systems and those barriers that exist in trying to do the work in the communities that you are working in. So Dana, you can get back to my other question if you want. I'll let you decide.
I'll try to kind of talk about both things together because I think your original question was about work that we are proud of
Right.
or something. Yeah, and for me, it's similar to the kind of work Ruben talked about, right? And we talk about it as community of practice work, right? And what that means to us is we're working with a community in its full form, right? And that means we're bringing resident leaders, youth leaders to the table. So for Ruben, that community of practice work, which lasted 6 years for him, and the one I'm about to talk about, I've been working on for almost 6 years. Unbelievable, right? But this is how long systems and the type of structural changes that we're trying to see in community environments is long-term work. And so, a part of our focus is really trying to get funders to see that you need to invest. You need to make investments in communities and populations that have been harmed the most. They need to be long-term investments, right? They're not 1 year, 2 year, 3 year grant cycles, right? Same thing with government, right? Our government funders and partners, we try to convince them of the same thing. But this is long-term work. For me, and I did work just a little bit, kind of the last year and a half on making connections with Ruben. But it then led us to a larger community of practice called Communities of Care. And Communities of Care is an initiative that we are still working on. We're finishing up the 5th year. I can't believe it. We started in 2019. We're finishing up the 5th year of that work in Greater Houston with 10 community-based collaboratives that are thinking about what mental health and well-being means for historically excluded groups, for Black and Brown communities, for low socioeconomic status communities. They're all, the thing is they all get to define who their population of focus is, how they define community. So for some, it's looking at African American mental health and well-being. But what they all have in common is they're thinking about it in the context of youth and their families, right? And they're thinking about it, who is historically excluded, right? Who has not been brought to the table, who has not been a part of decision-making and power building. And then thinking about it at the community level, right? What are the determinants of health at the community level that impact mental health and well-being? So for instance, I'll use Galveston. That is one of the collaboratives I work closely with and I'm so fond of because I've experienced this, right? Where I've seen that school to prison pipeline. I've seen Black boys. I have a son, him, Jocelyn, who go into school and, are automatically, treated differently and are not allowed to be young people and are adulterized. We see that with Black girls too. All the data says that Black girls are being adulterized now and not being allowed to act their age or given the same kind of deference that are given to other kids the same age. They are funneled into disciplinary systems and given different type of discipline than other kids that then sets them up, one, to not be in school because they've been suspended, two, not to receive the same type of supports that other kids who may be violating disciplinary practices in schools receive. Well, our Galveston collaborative came in and said, for us, we know that it's about addressing disproportionate and unfair disciplinary practices in our school district, right? And making sure that youth and their families know how to advocate, know how to go and speak to a school board, and advocate for what those changes need to be. And they started with kind of doing a review of school district policies. But there are 10 collaboratives there, and some of them are focused, like I said, we have 2 focused on Asian American mental health, which a lot of times Asian Americans don't get the attention, right? And are considered a model minority, and that label alone means people and stigma within their own communities, right? Similar to stigma within the African American community. I think we're making leaps and bounds to overcome that and overcome what that stigma means and how it may be a barrier to us seeking help or letting people know we're struggling with our mental health. But they identified that, and so they're working on those cultural things in their community that may prevent them from doing that work. So my work with those 10 collaboratives and the resident and youth leaders that we've come into contact with, and having a funder like the Hogg Foundation for Mental Health, who wants to learn more with us and figure out better ways to do the work, has made that work near and dear to me. I can say so much more about it, Jocelyn.
Listen, I can tell, just hearing you and Ruben, you're both so passionate about the work that you're doing. And Tyrone, thank you for putting up, just in case folks who are watching never heard of Prevention Institute, you're going to be blown away when you go to their website and see some of the things that they've done. And it's an opportunity, I think, for those of us who are working in communities now to maybe look at things different, right? Maybe they said something tonight like, I never thought of it that way. As we're going in communities, one community here in Northeast Florida, I said to some folks over and over again, when I came to the health department, I'm aging myself, but oh well, in 1982, I saw a community that was, it was okay. It was a good community. It was a decent place to live. However, I saw it change over the years. I saw Jacksonville growing, sprawling out, and the urban core of Jacksonville going down more and more. When I left in 2019, I saw a community just like, what happened? It's like all of Jacksonville moved, but this community is stuck in 1982 or even before then, right? And so as communities are growing, you can't leave a community behind, right? And drive home like, oh, those poor people. No, and that was just it saddened me so much. Like, you don't need to be retiring. We need to, really go in that community, put resources. We have a question on how single parent households may contribute to the perceived behavior issues. Anyone want to tackle that? Tyrone, you want to put it back up again, please? How single parent households may contribute to perceived behavior issues.
I'm not sure, we have it, that I have a frame for or a thought on responding to that. I think, one of our approaches is really not about blaming when we go into a community, but really looking at, what challenges are. I know during, COVID, kids went to being educated at home, right? But, one of the things I like to say is I had the privilege of, being able to work from home and support my, I didn't have little kids at the time, but had I would have been at home being able to, and I had a flexible employer, right? That moved to really thinking about what it meant for people to be working from home with their kids, right? And how could we support those folks? But what we know is that for people with hourly jobs, people most impacted by inequities and disparities, they couldn't afford not to go to work. So sometimes their kids were at home and they couldn't be there. So it's complex, right? And I think, instead of us labeling or blaming, and I'm sure Dr. Jones wasn't doing that because, he is another physician of the community. And so I don't have a lot of context. Another reason why I don't want to kind of speak on that too much. But I think our approach is really to understand what the challenges may be that families and households are experiencing, and how can we work to support them to overcome those. And make sure, one of the other things I want to say about, because you asked us to kind of talk about our lens for health equity and racial justice, and I know we're at time, Jocelyn, but I think it's so important because so long public health hasn't brought a racial justice lens to things. And I just want to say that that's incredibly important, that public health and folks doing this work aren't race neutral or race blind, because we know that racism, structural racism, and bias have shaped up certain communities and so that they experience the most harm. And so we need to bring that lens to things. And that's what I love about the work we do. We're educating people on why that's important. We've done a lot of thinking on this. So if folks go to the PI website, please look at our work called Building Bridges, and it'll tell you more about why we can't move away from bringing a racial justice lens to creating safer, healthier, more equitable communities.
And kudos to you, because it's a conversation. I don't know why people they don't seem to be, are they just uncomfortable with it? Or are they saying, oh, here they go again? No, it's real, right? And it's like,
it's really discouraging to see the attacks on DEI happening, right? Those are intentional attacks, right? And we have to be strategic. We have to build multiracial alliances to push back against those things, because they're not just harming one community, right? Those are to regress some of the policies that have happened over the last 50, 60, 70, 80 years. And so we have to counteract those regressive policies by looking to put in place policies that really are still about achieving a more equitable community for all people and a more equitable nation for all people.
And also having conversations with people who just don't seem to have a clue about stuff. I'm going to say it, Dr. Kane. I didn't tell you I was going to say it, but I was out in the community yesterday. I'm not going to name where I was, because just in case by some strange way the universe goes, I heard a woman say she hopes her candidate of choice for president is elected so that he could get rid of the IRS. And so I want her to understand what happens when you start dismantling systems that you think are impacting only you, apparently, right? But you don't understand the benefits of those systems, not just to you, but to the entire community. So I'll digress, but that was hot, Dana. I wanted to just confront her, but I decided I'm not going to go there, because people just need to educate themselves and not online all the time. Do it the old-fashioned way. Show up at meetings, tune into your city council meeting, and really educate yourself and get involved with reputable organizations, even though people don't seem to know what reputable organizations are anymore. But challenge yourself and ask the questions. Ruben, you unmuted. Looked like you had something on your mind. Go ahead.
I was just going to echo a lot of what Dana just said, and what you just said yourself, Jocelyn. We just got done doing a 1.5 year long project in Houston, where we were training Houston Health Department staff, all 1,400 staff people at the Houston Health Department, on how to embed equity and racial justice into their work. And doing that kind of work in the state of Texas is probably just as difficult as it is doing it in Florida. And I say that as a Texas native. I grew up and went to school in Houston, and my parents still live there. I mean, in Texas. And it was oftentimes difficult to have those conversations with the folks in the room, but the leadership at the Houston Health Department decided that they wanted to prioritize this and make this an organizational wide training effort to get everybody on the same page around what equity and racial justice meant. And we have to applaud the director of the health department there, Stephen Williams, who had the commitment to do that. And we need to do what we can to support and back up the folks that are trying to carry that kind of work forward, because it's hard to do it in the context of a state like Texas. Like we know people who have been affected over the last couple of weeks as the state has implemented policies limiting what the state can do to support DEI-related programs. And we know people whose offices have been shut down who work for the state or who work for the University of Texas system and other things like that. We need to support as much as we can the folks that are trying to do that work from within, because it's hard work in a lot of places right now.
So speaking of supporting, how can our viewers, because there might be some people who have they may be from a philanthropic organization, how can they support the work of Prevention Institute? Go to your website and check us out if they want to get involved or be.
So we,
giving.
we don't just work with philanthropy. We work with city and county governments. We do a fair amount. We have like 5 CDC projects right now. A lot of work with CDC, right? We work with other agencies, but we also work with community-based organizations. And sometimes we like the smaller contracts because that is where we are learning together and really building something together that we know is going to really address priority community needs. So, but if people want to know more about us, I'm Dana at preventioninstitute.org. Ruben is Ruben, RUBEN at preventioninstitute.org, and DANA at preventioninstitute.org. But we also have on our website a place where if folks want to know more or are interested in some body of our work, like our safety work, they can fill out a form, and we regularly check that, and we reach out and follow up on everything.
Thank you, Dana. Well, listen, we only asked you for an hour, and we've already stolen 6 minutes of your time. So
I'm gonna say, Jocelyn, I'm sorry. We can talk about this stuff all day, and I know I'm with like-minded spirits here. And if there's anything we touched on that you all would want to know more about in the future, I'm committing us to come back.
Well, thank you so much. Well, we like to give our guests an opportunity as we wrap up the show to share their final thoughts. And so, Dana, I'll start with you. What are your final thoughts regarding tonight's topic?
I think it's what I said last, right? I want to encourage us not to move in fear. I think a lot of the agenda, right, to ban, books in schools and ban DEI, and we see certain states kind of following that whole agenda. It's not just Texas and Florida. Other states are going to follow attacks on women's rights, all of those things, right? I just want to encourage us not to be so fearful, but to stay the course, right? And think about things in the context of what communities need and how to really be strategic about pushing back against those regressive policies that we're seeing happening now, but we can't do it moving in fear. So just want to encourage folks. And there are organizations, we know a lot of organizations like us that we work with on most of our work. We don't do anything in isolation. We bring partners in where we're not the experts to support us. So we're out there, just come to us, find us, and we will figure out how to support you.
Thank you, Dana. Thank you so much. Ruben?
Echoing some of what Dana just said, there's no way you can talk about health equity without also talking about race and racial justice and how so many of the decisions that impact our health and safety were racially motivated. And so if we're going to talk about it as part of the problem that racism has led to these problems, we also need to talk about racial justice as a solution. And doing that work requires having difficult conversations, and we need to not shy away from those difficult conversations.
Thank you, Ruben.
It's uncomfortable, it's messy, but we need to do it.
Necessary conversations and work. Thank you. Dr. Kane, what are your final thoughts?
Well, one of the things that I just kind of want to bring home is that in order for work like what work that the Prevention Institute is doing and other organizations are doing, the basis of a lot of this healthcare disparities or is has been addressed to a great degree. It was addressed to a great degree, not completely and not at the, absolutely, but with the Affordable Care Act. And currently, Congress Republicans are looking at slashing $4.5 trillion away from Affordable Care Act. And if you can take monies and send them all to overseas to take care of other people's health care needs, because a lot of these monies that go on overseas are taking care of their health care needs, then you need to go on ahead and approve the budget that we need here to take care of this country's healthcare need. So, you know, when you start teaching advocacy mechanisms, which I think is what some of the things that the Prevention Institute does, I think what they, you know, what we need to focus on is how we go back and deal with our congressional leaders in terms of them voting to slash this $4.5 trillion away from ACA and Medicaid and CHIP programs, that so that we can treat and address the disparities within our own individual communities. This whole social determinant of health as it relates to housing, education, you know, all of that needs to be addressed by not only organizations like the Prevention Institute, but people within the community themselves, for whom people at healthcare, the Prevention Institute is trying to go out and help them achieve equity in healthcare. The last thing I'm going to say is just comment on what Tyrone presentation was about 40 acres and a mule, 101. Okay, 40 acres and a mule 102 was when our soldiers came back from World War II, and all the redlining and the disparities that took place with the healthcare program and the housing programs and all the other stuff that the government elected to keep from our community, whether they did it themselves or allowed it to happen with the banks and all the people, the financial institutions. So we have to remember that it's not just the government or that is the culprit behind this, but private businesses, private equities, things that are taking our money and using it against us to develop all the communities except ours, including those that are overseas. So we need to start becoming our own advocates. We appreciate what organizations like the Prevention Institute does, but at the end of the day, they can't be everywhere. We need to step up and speak for ourselves and support people that are out there on the front line. Not myself, but anybody from NAACP to Urban League, the Prevention Institute, you name them. We need to get out there. And lastly, vote. I know that there seems to be some disparaging news coming from our nation's capital about voting, but if we don't at least make the statement, whether we win or lose, we need to at least make the statement that this is what we want, and try us again next time, because if you don't do it this time, we're coming back with a vengeance.
Thank you, Dr. Kane, and thank you, Dana and Ruben, for your insight, and we look forward to having you again. Health equity, again, we always do our homework, and when we talk about health equity, it refers to the principle of ensuring that everyone has a fair opportunity to attain their highest level of health. It involves addressing systematic differences in health that are closely linked with social, economic, and environmental disadvantages. Racial justice, on the other hand, involves the fair treatment and equal opportunities for all people, regardless of their race or ethnicity. In the context of health, racial justice means addressing disparities in health outcomes that are often rooted in systemic racism and discrimination. Together, health equity and racial justice aim to eliminate disparities in health outcomes and ensure that all individuals have the resources and opportunities needed to achieve optimal health. Thank you all for tuning in to Pause for the Truth. Thank you again to our guests. And don't forget to subscribe to our YouTube channel and tune in next week. We're going to have an even greater and insightful conversation. Good evening, everyone.
And there we have it, another episode of the Pause for the Truth podcast in the proverbial books. Our heartfelt thanks go out to every one of you who took the time to tune in. Mark your calendars. We're here every Tuesday at 6:30 Eastern Standard Time. Feel free to join our community on Facebook, Twitter, and LinkedIn. But the golden ticket? Subscribing to our YouTube channel. That's your passport to all our latest episodes and exclusive content. A special mention to the wizard behind the curtain, Tyrone Jackson from Call Tyrone IT Services. His technical prowess and unwavering dedication are the backbone of this podcast. Next week, we'll be back with more. Until then, tell your